Thank you very much, and thanks to all of you for staying, for listening to this lecture, which will be a good deal different because we're focusing on leg ulcers. Now, I'm just explaining to you that there are images that we are using, and the purpose of the images is to tell you the story around it. It's not meant in any way to alarm or to shock you, but it's to share the story with you so that you can understand exactly what we're speaking about. So I'll explain to you in a moment why we chose the title of Leg Ulcers More Than Skin Deep, and I hope that by the end of the presentation you'll be able to understand why this title is very important. So as Maria said, myself and Julie, we're best pals as it happens, and we're also colleagues at work. And I'll start, and I'm going to talk to you about the definition of a leg ulcer, the importance of diagnosis, talk to you a little bit about causes and about the number of people who have leg ulcers in Europe and in Ireland, and what impact that has on the person themselves who suffers with it. And then what are the tips then for getting it right? And then I'll talk just briefly about assessing the person with the leg ulcer. But Julie will move on then and talk more about assessing the circulation and the different types of treatments that we use. So a definition of a leg ulcer is that it's a loss of skin below the knee, on the leg or foot, which takes more than 6 weeks to heal. Now, maybe by the end, we could possibly go back and revise this definition, because I guess if we understand the causes of the problem, perhaps the causes are there at the very moment you notice a wound on your leg, and therefore why wait 6 weeks for it not to be healed? Maybe the best thing to do might be to go and get treatment immediately. But if we look at it from a person's perspective, these are figures from the United States, but I just think that they really give you the picture of what's happening to somebody when they have a leg ulcer. So about 2.5 million people per year in the United States have a leg ulcer. And the average venous ulcer takes about 6 to 12 months to heal completely. But the problem is that about 70% of them will recur after 5 years of closure. They're painful, and they cause a loss of an estimated 2 million workdays. Now that is the person themselves who's suffering with it. Because I guess in reality, if Julie and I were in the clinic still, we would be employed to take care of people who have leg ulcer. So the point is that we get money from it, but the person themselves is losing out enormously by having this problem. And the costs in the States is estimated to exceed about 3 billion. So it just gives you a flavour of what that's like. We'll talk a little bit more about it. So why we chose the title of Leg Ulcers More Than Skin Deep is because the term leg ulcer, it's not a diagnosis. They usually arise due to an underlying disease process. And therefore, it's absolutely vital that you get a correct diagnosis, because the treatment of the problem is based upon the diagnosis. So if we don't know what the cause of it is, we have difficulty in managing it. And that would make sense in everything you do in your life. If you don't know why the roof is leaking, how are you possibly going to be able to fix it? You need to investigate why. So here's an example. And you can see, even looking at it from your own point of view, you'd imagine that this person has quite a lot of problems going on. So a very extensive wound with skin-associated problems. Now imagine if that wound is itchy or the surrounding skin is itchy, and then I say to you, don't scratch. But at night time, in the heat of the bed, the itch becomes worse and worse. So oftentimes it's all around the surrounding problems that significantly impact on the experience of the person. So I put up this picture then of the iceberg to try to bring home to us that what we're looking at on the very outside of the skin is a manifestation of something that's going on underneath. And I think that if people could understand that, then they would go, as we say in the European Wound Management Association, with your wound rights, and say that you have a right to know what the cause of your problem is. Because now we understand that the manifestation is happening within the body, with the wound just being a symptom of that, as it were. So there are many common causes of leg ulcers. They could be caused by our venous supply. They could be caused by our arterial supply. They might arise because I have diabetes. They could arise rarely because somebody has a cancer. Or they could be caused by a variety of different things. For example, that somebody might have a burn injury with an underlying problem with their venous supply and then the wound doesn't heal. So there's a lot of different reasons. But if we look at the studies from O'Brien and Grace et al. Here in Ireland, they suggest to us that from an Irish perspective, the prevalence of leg ulcers is about 0.12%, but rises to 1.03% in people who are 70 years and older. So as we increase our age and we know that the population demographics are changing, well, it's likely that people will develop these problems unless we take preventative measures into place. Unfortunately for us females, we are twice as likely to be affected than our male counterparts. But venous disease accounts for about 81% of ulcers, where arterial disease is only about 16.3%. So for the purpose of the rest of this lecture, we're going to be mainly focusing on venous disease because there's quite an active management programme that you yourself can use in order to help this problem should you have it. But I suppose as humans, in everything that we do in our lives, it's often about how we feel. So if we're having a treatment for something or we're suffering with something, somebody will say to you, how do you feel? What is it you're complaining of? And for me, it hits home all the time that when you think that this is 2014 and that people who have leg ulcers suffer pain, 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 pain. So if you could imagine what that's like for yourself, that you would have pain, and that maybe that pain is not very well managed, and it has a significant impact on your quality of life. Because you can imagine that when you're in pain, you definitely will have less vitality. People with leg ulcers tend to have a poorer psychological well-being. And then importantly, from a societal perspective and that person's contribution to society and their feeling as an active part of society, they have restrictions in their work capacity, in their recreation and social interactions. And many times they may need to change their occupation because they haven't had this problem managed well in the beginning. Whereas if at the outset we get a good diagnosis and a good treatment regime going, the outcomes can be very, very successful. But the other thing is that whilst they have the problem, they have to deal with all of the complexities of having treatments at the same time. So that might mean having to attend a clinic, whilst you're working, having to rush to the clinic, have your treatment, then try to get back into work and to pretend to nobody at work that you're going off to have this treatment. So there's a lot of issues for the person in trying to manage the treatments as well. So from the physical symptoms, I'm reminding us again about the pain because it is one of the primary things that people will complain about. But if you could imagine for yourself that you have a wound and that wound is leaking, and say you want to go to the wedding on Saturday, but it's not time for your dressing to be changed, and yet you can notice a smell from the wound. And that would say to you, I won't go. I won't go to bingo. I won't go to church. I won't go out because I'm nervous and afraid about this smell. And of course, all of this will contribute to an altered body image. So the person just doesn't feel like themselves and doesn't feel like contributing as they normally do. And of course, if in the presence of pain, all of us know this, that you will have a likelihood that you have an impaired mobility as well. And yet, mobility is very important to prevent the symptoms of the problem in the first place. So sometimes it can be like a catch-22 situation, which reiterates to us the importance of recognising that the wound is often a symptom of something else happening, and therefore we should go and seek advice. So once again, it's only to bring home to you what the experience might be like for somebody who has a wound such as this, which is leaking exudate, which is foul smelling. And can you imagine now as we put the electric heat or the heating on, whatever it is we have, and then you walk into the bedroom in the morning, what that smell must be like. And then I must feel good about myself in an environment like that. And that's the challenge for us and the challenge that people face on a daily basis. So in terms of the financial impact, we're looking here at figures from the EU, and it's suggesting to us that the prevalence among the EU population is about 1.3 million. The incidence then is that is the number of new leg ulcers that will occur in, say, on a yearly basis, would be about 980,000. The cost per episode of care is 6,650, And the indicative annual cost within the EU is about 6.5 billion. So if anybody wants to say that this type of problem for people is not important, it is a very important. And some people consider it to be a Cinderella of problems because not everybody considers it in the context of the impact it has on the person and on society as a whole. So fundamentally, if I have a reduced blood supply to my limb, so to my leg, then I will have reduced oxygen and nutrient supply to my skin. A simple trauma could happen that you turn over in bed, a little bit of hard skin on your ankle, scratch your leg because it's a little bit itchy, and you break the skin on your leg. And that leads to ulceration because in order to repair that, we require an adequate blood supply to the limb. So a typical example like this, where the person actually has a trauma, so the person is out shopping and they get bashed by the shopping trolley, come into the emergency department. It looks like just a simple wound, but unless we make a proper assessment of the person, of the underlying likelihood that there could be problems for healing, then this will go on to be a long-term wound that we could have addressed properly at the very outset. So clearly then, improving the outcomes in leg ulcer management is really dependent on identifying the cause and then planning your treatment around correcting or reducing this cause where you possibly can. So the reason why I have this megaphone here is to try to explain to you that if we have swelling in our leg, it is a major problem in terms of healing. So could you imagine if I was standing in Stephen's Green Centre trying to deliver this lecture to you in this room without any microphone or anything? That's kind of what oedema does. It impairs the communication between cells, and the cells need to communicate with each other in order for the wound to heal. So if I have any swelling in my leg, I am decreasing the possibility of healing. So where possible, we have to address this swelling in order to get the wound to heal. So the megaphone reminds us that really we need to have focus on getting rid of the oedema in order that our cells can communicate. But the problem is that in a recent study by one of my own students, of clients who had leg ulcers, only 43% of them had been assessed correctly. So that means that 57% of them are with a wound that isn't properly assessed and managed. So they are suffering day by day by day, yes, maybe having dressings applied, but not necessarily having the right treatment. And in those who have venous leg ulcers, and Julie will talk more to you about compression therapy, it should be used in patients who are ambulatory and who have venous leg ulceration. But in this study, only 53% of the clients were using it. Now, the studies show that if we use compression therapy, 75% of the patients with leg ulcers will heal within 12 weeks. So imagine a trajectory of 12 weeks or a trajectory of 12 years. If the person knew that, they may well have chosen the compression therapy in the first place, providing, of course, that their supply to their limb, their arterial supply to their limb is good, because that is the fundamental thing we need to check before we use compression, and Julie will talk more about that. You see, the trick with wound healing, imagine the human body is absolutely amazing when you think about it. And little did we know that wound healing is a very finely balanced sequence of events. I never really realised that until I started studying about it. And that every part of wound healing, when it's occurring as it should do, is switched on and switched off by stimulators and inhibitors that are naturally produced by your body. Little did we know as we're sitting there that those processes are going on. So if I have a problem with my blood supply, so that the cells that are required for wound healing don't get where they should do, or I have oedema in my leg and the cells can't get there as quickly as they should do, then my processes that should be switched on and switched off, that doesn't happen. And imagine bacteria get in, as they do. If you break your skin, bacteria will always get in, and the bacteria have a heyday, swimming around delighted with themselves because there are no cells to combat them. It's like being at a party and along comes a guard who's like 4 foot. Could you imagine? You'd want somebody like Arnold Schwarzenegger to come to the door to protect us. So you'd be thinking, I want the cells to be here to be able to do the job that they're supposed to do effectively, because if not, I will have impaired wound healing. Just as an example here. So can you imagine what this is like? And if we were able to get to the bottom of the problem, we would be able to get things back on track. Because the only way to restart the wound healing process is to reverse the imbalance within the wound bed. So if we remember that in our heads, then we never take it lightly that we have this sort of wound. We say to ourselves, I need to do something about this. So the key to success is really seeking specialist advice early. And specialist advice can be taken from your general practitioner, from the practice nurse, or the public health nurse, or if you're already attending a clinic, to revisit that clinic immediately when you notice that you have problems. Because our assessment focuses on 5 different areas. We look at the patient, we look at the limb itself. When we're looking at the limb, we're also checking out the circulation. We look at the wound, and we look at the surrounding skin. So it's quite a detailed process, but once done correctly at the outset, will give us the answers we need to be able to move the journey forward. So from the patient's perspective, we look at the patient's past medical history. If they have a medical history, perhaps everything is very stable. For example, their asthma is well under control, their diabetes is well under control. We look at what medications they're taking currently, and also we look at their weight and whether or not they're a smoker. And all of this gives us some idea of, can we get a picture of what might be going wrong with that person as to why their wound is not healing. We also ask the question whether they have a history of having had a leg ulcer before, whether they have any evidence of varicose veins, or lipodermatosclerosis, which I'll show you a picture of now, or did they have a limb fracture in the past, which might give a rise for them having had a clot in their leg, for example. So here's somebody who has varicose veins. So the question would be that if this person had an accident, for example, playing football or rugby or whatever it is, and presents to the emergency department with a wound on the leg, we need to be able to assess the fact that they have the varicose veins there and then, because they're staring at us in the face saying there's a potential for poor wound healing there. So I wouldn't be waiting for 6 weeks, I would be managing that immediately. When we're looking at ankle flare, you can see there, so it's a distinctive vein pattern which is common on the medial aspect of the ankle as a result of distension of the veins. All of this is giving me a picture as to whether the person would have problem with their veins, and that way they're healing. And then this lipodermatosclerosis is like a hard, woody, brown pigmentation on the skin, which is indicative of somebody having a problem with their veins. And so all of those give us some idea when we're looking at the patient as to what might be going on with them. So now I'm going to hand over to my colleague Julie, and she's going to take you through these, but I'll let her introduce that to you herself. So thank you very much for listening to me.
Thank you, Zena. Thanks for a great talk. The focus of this lecture is actually on venous leg ulcers because they are the most prevalent in the literature. Just before I start talking about the assessment of the circulation, I'd just like to point out that everybody is unique and every wound is unique, and even though we get lots of different patients coming into the clinic with the same problem, how we deal with them and their various history, as Zena already pointed out, and their assessment is very, very different. So everybody is very individual and everybody's needs are kind of met in the clinic. So when we're doing the assessment of circulation, it's not only important, I suppose, to look at the way the blood supply is to the lower limb, as Zena said, it has to have oxygen and nutrients to heal, but also to look at the venous supply as well, where the blood has to travel back from your little toe right to your heart. And that takes a lot of gravity and a good venous system to work. Of course, the assessment of circulation, there's lots of different tools that we can do in order to do these assessments. And it's very important that we consult with our colleagues in dermatology, in plastic surgery, in vascular surgery, and all of the multidisciplinary team to make sure that the right plan of care is set for that patient at that particular time, as Zena said, to prevent complications in the future. And it's also important to point out that not everybody's wound will heal, and sometimes it's about management of symptoms and not really about healing the wound. But if it's a simple venous leg ulcer, and if the proper assessment is carried out and the etiology is right, compression is the regular treatment and is the evidence-based treatment for venous leg ulcers, and they should heal within 12 weeks. So I'm just going to point out a little bit about the skin assessment, and then we'll focus on wound assessment very briefly, talking about skin care, dressings, compression therapy, and some take-home messages. So for just a couple of minutes, I just wanted to point out these lads out down here are the most important things on this. This is a venous system, and basically the long and shorts of venous veins have a long way to travel to get the blood back to the heart, as I said. And these little perforator veins here allow for superficial veins to drain back into the deep veins so that they can travel back to the superior vena cava. And the problem is that when these don't work sufficiently well enough, you get some ulceration down around the ankle because the blood doesn't go back, it goes out into the interstitial spaces and into the skin area, and it becomes itchy, and then, as Zena said, you get some ankle flaring, maybe some varicose veins and some hemosiderin staining into the tissues, and that gives that typical kind of brownish kind of colouring to the skin. So if we just talk briefly about a normal venous return, so the blood is propelled back to the heart with the changes in the shape of your calf muscle and your leg as it moves. So dorsiflexion, will help the calf muscle to contract. Okay, so that's really important. And this forces the blood inwards to the deeper veins from superficial veins, and it compresses the deep veins. The one-way valve forces the venous blood back up towards the heart, defying gravity all the way. And the valves in those little perforators that I showed you prevent the backflow of blood. And plantar flexion, then, when the muscle relaxes, the veins then refill again and the whole system happens again. So very simplified, it's like a pumping action in your leg that's happening. And walking is the most effective way to activate the calf and foot muscle. So here we have an abnormal vein then. So this is the deep vein here where the blood is propelled back to the heart. And if you look at the perforator here, there's a backflow of blood into the superficial vein. And this gives the dilated and tortuous kind of visual aspect that Zena showed of that gentleman with the varicose veins. So you get an abnormality of high pressure, the valve doesn't quite meet, so there's a pooling of blood, and then these become tortuous and ligated, and they're more pronounced. So if you can imagine the valve doesn't quite meet, the blood doesn't go that way, it goes out into the tissues, and there you're going to get an abnormality. So during venous incompetence, it's a failure of the calf muscle pump to work. You get pooling of the blood, venous hypertension, as I said, and calf muscle pump failure is the main etiological factor that presents in patients with chronic venous ulceration. So lots of people think, oh, I have to sit down and I'm not allowed to walk. It's quite the opposite. Walking actually helps the mobility and helps the blood supply both to and from the wound. So even if the patient cannot walk and their mobility is quite poor, we would very often give them dorsiflexion exercises and ankle rotation to do whilst they're in bed or in a chair. And that really keeps the calf muscle pumping. So of course, a vascular assessment is a part of the circulation assessment. It's really essential. We want to find out, what is the arterial blood supply to the wound. And if compression is applied to somebody with arterial disease or ischemic damage, you could result in some further damage to that person. So it's really important that we do a proper vascular assessment to make sure that we don't cause any damage. Okay? Or you have a tourniquet effect and you can have a necrotic toe or necrotic damage to the limb. And this is just showing you a picture of damage from compression therapy to a limb that hasn't got adequate arterial blood supply. So there's lots of various vascular assessment tools. We have a palpation. You can actually go and feel the pulse yourself, or you can listen to it on a Doppler. And then we have a test called an ankle brachial pressure index test, whereby they check the systolic pressure of the arteries in both the upper and lower limbs. And this is a really important test because we use this test to find out what the blood flow is like to the lower limb in order to ensure that it's safe to apply compression. Okay, so that ankle brachial pressure index is really important to carry out before we put the patient into compression. And that can be done in a vascular lab, or it can be done in the local health centre. There's lots of public health nurses who conduct this in their own leg ulcer clinics. Pulse oximetry is another way of testing the blood supply to the lower limb, and it's simply a little measurement or a little cap that goes on a toe, and it tests the oxygenation, and you can hear the pulse as well. Okay, so it tells you that there is actually a blood flow to the limb. There's lots of other vascular assessment tools out there. We don't have enough time to go into them, but there are lots of vascular surgeons who would, maybe do some X-rays, some magnetic resonance imaging scanning, duplex scanning to outrule clotting. There are lots of various tests that they can do these days. And then if they do find that there is a problem emerging with the blood supply, angioplasty or maybe taking the patient to theatre for bypass or grafting is essential before they can treat the leg ulcer. Okay. So just to talk a little bit about the venous stasis eczema, and Zena mentioned this already, it's very, very typical of venous leg ulcer disease, because what's happening is the blood supply is not getting back to the heart, so therefore the toxins and the build-up of nutrients or the build-up of toxins that we don't need can't get back to be excreted in the kidneys, and therefore you have this toxic fluid kind of seeping out into the interstitial spaces, and it causes weeping and blistering and itching, and then unknowns to yourself in the night you might actually use one leg to scratch the other leg, and hey presto, you get a breakdown of skin and ulceration, as Zena already demonstrated. So managing venous stasis eczema is really, really important and quite simple to do without actually, prescribing too many medications if it's treated regularly and topically. Simple emollients are enough usually to keep it under control, but sometimes we have to prescribe corticosteroids. So stasis eczema presents sometimes dry, sometimes it's wet, because you've got the leaking going on, as Zena said, the leaky tap. You've got some erythema, and sometimes I suppose if people see erythema they get a big fright and they think, oh, it's a mega infection and I've got a cellulitis here and I need antibiotics, and that's not the case at all. Very often corticosteroids can treat that inflammatory response and get the swelling down and get the redness down so that there isn't any infection at all. Scaling is very common with it, and instead of picking off the scales we would always encourage people to wash and soak and moisturise rather than going at it and causing more a transfer of infection from their hands to the wound. Associated with ulceration, and then of course if you're scratching and your hands aren't washed, you're going to get infection, and contact dermatitis is quite prevalent amongst the venous leg ulcer population because they are exposed to multiple types of dressings and topical wound treatment agents. And I suppose they sometimes have sensitivities that can trigger an inflammatory or a hypersensitivity response. So therefore we would sometimes get dermatology to see these patients, and the patients are very often patch tested to make sure they have no allergies to any of the treatment or topical compression therapies. So when it comes to assessment, we're looking for the actual wound itself. And I would say that when we look at somebody's skin, we examine everywhere in the skin. It's not just the wound we focus in on. You're looking at both limbs, you're going to compare both limbs, you're going to check the circulation on both limbs, you're going to ask the patient, do they have any itching or any rash anywhere else on their body? Where is the pain? How bad is the pain, as Zena mentioned? And then the condition of the wound bed is really important as well, to see what is going on. Actually, are we suspicious? Is there infection? Is there too much exudate going on? How can we manage the oedema? How can we make sure we have the right etiology of this wound? Because sometimes over a period of time, wounds can change and cells can change. So sometimes if somebody's not responding to the right treatment and we think we have the etiology right, we might have to do a biopsy to actually diagnose whether there's a malignancy there or whether the cells have changed. The condition of the surrounding skin is really important because this is where your new cells actually heal your wound. So if you have a wound that's contracting nicely and is healing, fantastic, because the surrounding skin can epithelialize and travel across the wound bed to replace the cells that have been lost. But if you have a surrounding skin that's completely macerated and wet, i.e. somebody looks like they've been in the bath too long because the exudate is now seeping out around the wound and causing a corrosive reaction to the skin and more itching and more swelling, then you're not going to get to heal that wound. It's going to spread, it's going to get bigger, and it'll look like a map that's travelling around. And then eventually it'll go circumferential and the whole limb, and then that's even harder to heal. And the amount of fluid that comes from the wound is really, really important. So we look at not only how much fluid is coming out, but what is the colour of the fluid, what is the odour of the fluid, do we need to analyse what's living in the fluid, do we need to manage the serous exudate with bandaging, and sometimes people will say, oh, it's completely soaking, I'm not even getting 24 hours out of the dressing. It's really frustrating for them, as Zena said, really painful and really socially isolating for that person. So we have to make sure that they have the right compression on, and when you sort out the pipes, the tap will stop leaking. Okay, so that's where we're looking at, have we got the etiology right? And here's a venous leg ulcer on the lower limb. And very often venous leg ulcers occur around the lower third, okay? Because if you can remember, the perforators are the ones that get into trouble, and then they cause the distension or venous hypertension in the superficial veins, and then you get leakage out into the skin. So this is a small venous leg ulcer over the lateral medial or lateral malleolus here on the lower limb. It's not particularly infected, and it does appear to be shrinking in size, so that's good. This wound is healing. But again, you can actually see, I don't know whether you can see there, there's a little bit of wool attached to the person's lower limb. With the proper skin and moisturising and compression, this should go on to heal. Now, there are lots of ways we can manage how do we know the wound is getting smaller, okay? So we use rulers, we use depth indicators, we use photography, and we use some tracing as well. And this can be kept then as a record in the patient's chart, so that every week when they come to clinic, the wound is measured once a week, and we would hope to see a difference of about 0.5 centimetres on a weekly basis, and the wound is actually getting smaller, and then we know that we're on the road to healing. If it's getting bigger, we need to question, why is it getting bigger? Do we need to go back and re-examine and re-explore, have we got the right etiology? Okay. So here you have a typical venous leg ulcer as well. They're very irregular in shape. They're not like an arterial ulcer. Arterial ulcers are due to poor blood supply. You know, going to the limb, we're talking about venous return here. So venous leg ulcers tend to be irregular in shape. They tend to look more superficial, more like a map of an island or something like that. And they tend to weep more than arterial leg ulcers. Arterial leg ulcers tend to be deeper, round, and more, I suppose, not as much exudate that there would be coming out of a venous leg ulcer, because the fluid has to go somewhere. Okay. If somebody has a poor blood supply, or if their ankle brachial pressure is very much reduced, we would rapidly access the vascular team to do an assessment to check for that, to re-vascularize the lower wound. And there's lots of literature out there that says that if patients don't reduce their wounds in size, it's suggestive that they're not responding well to treatment. So we need to do a weekly reassessment. And I would always say to the nurses on the wards when I work in Beaumont is have one problem that you want to solve in that week. Okay, not to write down the goal of I want to heal the wound, because you might never achieve that. But the goal would be to manage the infection, to manage the exudate, to manage their pain, to help that person mobilise to the bathroom and back by the end of the week. And these are kind of achievable goals that even the patient can get involved in, feel they're participating in their care, and feel that they're actually making some progress. But if you say I'm going to heal the wound, and then 6 months, 12 months later the wound is still not healed, it's quite frustrating and incapacitating for that patient. So infection is one of the key things that is a big problem for people with venous leg ulcers. As you can imagine, as Zena said, if you have a really moist environment, and the fluid has to go somewhere, so it's going to come out the hole. Bugs love moisture, they love heat, and there's a nice happy medium of dead tissue there for them to thrive on and to feast on. So of course they're going to populate there, and of course they're going to multiply. And this is when we run into problems of Pseudomonas infections, where patients are managing quite well, maybe they're in compression, and then they stop wearing their hosiery or the compression, and suddenly it starts leaking again, and it starts getting bigger again, and then they get infections again, and it gets more painful again. Pain is a really, really, really huge factor, as Zena said, and we look at lots of different ways to manage their pain, not just pharmaceutical and chemical ways of healing their pain, but also maybe of some of the mental health awareness, meditation, relaxation, and taking the focus away from their leg ulcer so that they can actually get some sleep. And if you get sleep, you cope better, you eat better, everything is much better. Odour can be a huge problem for patients. I think I'm totally immune to smell now at this stage in my career, so I don't always get the smell, but if it's a problem for the patient, I think it needs to be addressed, it needs to be recognised, and there are topical charcoal or deodorising dressings that we can apply under compression to make sure that that patient feels confident going out to bingo or the shops or whatever it is Zena was talking about. And the surrounding skin is really important that we manage it so well. Not only is it because it heals from the outside in, but also because we don't want the wound to get bigger and macerate and spread. And we want to make sure that their venous stasis eczema, which is, a very, very common problem with venous leg ulcers, is managed appropriately. And very simple emollients like Silcox base, some of the very, very basic emollients, Emulav washes that you can buy over the counter are really good ways of washing in between dressing changes to ensure that the patient's eczema is managed as well. So unfortunately, as Zena said, this is not to alarm you in any way, but this chap came to clinic with a Tesco plastic bag around his ankle. I mean, it's so sad to think that something as simple as the right compression therapy could actually heal this. And he's walking around with like a few Gamgee and a bit of sellotape holding on his dressing, and then a plastic bag. And you see the way the foot is totally macerated there from pure leakage. And leakage, gravity never lies. The fluid will always fall towards the floor. It won't fall up the other way, unless your leg is in the bed, and then it's going to leak up the other way. But generally speaking, wounds leak down towards the floor. And that's why sometimes with venous leg ulceration, we will put extra padding or extra wound care products around the ankle to make sure that they don't actually seep out and don't cause distress for the patient. Okay, so that's a really nasty infected cellulitis, sloughy, kind of all this skin here is dead, needs to come off, and we need to consider ways to do that using topical wound therapies or consulting with the vascular surgeons. So treatment really is about good skincare, the correct dressing, management of the infection, and sometimes we have to use systemic antibiotics. Sometimes these people are admitted to hospital for IV antibiotics to treat the cellulitis in order to get on top of the infection, and then they will tolerate compression, because some patients find it just too painful to tolerate anything tight on them. You can imagine if you're inflamed and your finger is actually peeling, if somebody put a tight dressing on it, it's going to actually annoy you. Analgesia, control of the oedema, as Zena said with her megaphone, and compression is for venous leg ulcers. So what you really want to do in the treatment is wash gently in warm tap water. Now there's lots of debate in the literature about whether you should use saline or tap water or antiseptics or what you should use for cleansing. Now sometimes if patients have really bad overt infections, we use potassium permanganate soaks, but it can sting the limb, but it does help to dry up the wound. But most of the literature reports that warm tap water is perfectly fine to wash the patient with. Okay, we're not talking about, putting them in a bucket and going off for 2 hours and coming back. You're just talking about gently cleansing. And that's really, really nice for the patient as well, because in between dressings, if you've been wearing compression for up to 7 days, of course you want to shower. Of course you want to feel human and feel good about yourself in between. So what we do is we wash the limb separately in a lined basin. And the reason why we line the basin is if people have bilateral leg ulcers, you don't want to transfer an infection from one leg to the other. So you're going to dispose of the liner and put a fresh one in and do the other leg then. Okay. We use emollients to help keep the skin supple, and we avoid any perfumes or any soaps, anything like that. Nothing like that for washing. Avoid trauma if you can at all. Wrap them up as much as you can and pad them out. And then we use topical steroids only as prescribed. Okay, we don't kind of say, oh, I have a bit of eight in the cupboard here, I'll lash a bit on and it'll be grand. You can't do that. There are regimes for using topical steroids or even systemic steroids, and they should only be used where they're prescribed and only for short periods, because if you overuse the topical steroids, it thins out the skin, and then the skin is more prevalent to breaking down as well. Okay, so they are very, very useful. I would advocate topical steroids, but only where prescribed or as indicated. So the treatment really is about treating that oedema, using your emollients, your anti-inflammatory agents, which your topical steroids or anti-inflammatories, and anti-infective agents, systemically or topically. And we have dressings with anti-infective agents in them as well. And then support bandaging is really, really, really key. If you look at any of the literature, it says that venous leg ulcers, doesn't really matter what you put them on as a primary dressing, it's the compression that works. Okay? So there's over 10,000 dressings, believe it or not, and you can see how much Zena put up their epidemiology factors and the cost of dressings in the US and how much it costs wound care in Ireland. And if we got the etiology right and if we got our diagnosis right, we will be using these 10,000 dressings more appropriately, because people will be in the right ones at the right time and not having people undiagnosed out there and not wearing their compression. So really treatment then is about, how do we decide? I mean, some nurses actually in health centres have so many dressings in the cupboard they don't know where to start, and they very often say to us, I know there's lots of dressings there, but I'm not really sure what they all do. So from my reading in the literature, it does say that just topical, non-adherent dressings, something that's going to keep the wound moist, but not too moist, is going to absorb the exudate if you have a lot of wound fluid production, is going to keep the wound bed condition nice and warm and not disturb it, is going to have the dressing characteristics to absorb that exudate and maybe to treat topically. And then, of course, the patient is very important involved in that process as well. So when I do a wound assessment with a patient, I will ask them, what have they tried so far? What works for you? What are you comfortable with? What do you think you're allergic to? Have you ever had patch testing? All of these questions are really, really important and pertinent. And of course, with the internet now, people are looking up and everybody wants honey on their wound. Oh yeah, everybody wants honey. Honey's great. But honey isn't always useful for venous leg ulcers, because what honey does is it increases the osmolarity of the wound and it creates more fluid, which is the last thing you want in a venous leg ulcer. But it has its place, and sometimes in fluffy leg ulcers with venous problems, we will use it as a primary dressing under the compression therapy. Okay? So that's important to know. So at various stages of healing, we have different types of dressings. And as I said, we talk to the nurses on the wards and we say to them, what is your goal of the week with the patient? What are we trying to achieve? Because what happens sometimes is somebody comes in on a Monday shift, puts something on, somebody on a Wednesday shift tries something else, somebody on a Friday shift tries something else, and you have 3 different dressings going on, and the wound hasn't had a chance to, get used to the atmosphere for it to work, to be active enough. And what we do is we do an assessment once a week and then do a plan of care for that week. And if the plan of care means that the dressing has to be changed once or 3 times or 5 times, depending on the amount of exudate that is there, ideally you want to get the longest wear time out of that dressing to get maximum efficiency both for you and for the poor old patient with the pain, but also to make sure it's cost-effective use of your resources as well. Now there are lots of good articles and there are lots of good guidelines out there, and the principles of venous compression are available. If you go on the internet you can find the SIGN guidelines. There's very useful patient information leaflets there. There's lots of useful literature. But I've taken this from the SIGN Guidelines Network in 2010, and it really reiterates what the literature tells us, that compression really is what's useful for treatment. This includes hosiery, so your compression denier tights, tubular bandages and bandaging systems that comprise of 2 bandages, or some people would try 4 bandages. But what you're trying to achieve is an even constant pressure on the lower limb to get that valve to do this and not do that. Because when it's like that, the blood's going this way, and when it's like this, it's going that way. Okay? So you want a graduated compression to the lower limb to improve venous return and reduce the oedema. So it reverses the venous hypertension, it directs the fluid away from the interstitial spaces back to the vascular and lymphatic compartments. And as Zena said, we want to make sure there's a good blood supply to that wound in order to heal it for oxygen and nutrients. And if you have a lot of fluid in the way, it causes a narrowing of the arteries as well. So by reducing the fluid in the interstitial spaces helps to improve the blood supply to that limb. So your hydrostatic pressure is the thickest around your ankle because that's the narrowest bit, and then as it goes up, it gradually goes out towards the calf as it gets bigger. So progressively it falls towards the top of the limb. And if you can just imagine in your mind's eye, what we're trying to do with the bandages is a bit like a giraffe. A giraffe has very stiff, static skin on its lower limb because the blood supply has a long way to get back up to its head and its heart. So what we're trying to do is create a compression around the lower limb to actually get those valves to close and get the blood back. But there are factors to consider when you're choosing your compression system, and for me the most important thing is the quality of life issues for that patient, because you're the one that has to wear them. It depends on what your job is, what your hobbies are, and what you want out of your day. Okay? And then mobility is important too, because the calf muscle pump, as we said, has to work if you're mobile in order for the blood supply to go back to the heart. But if you're laid up maybe with a heart attack or something else and you happen to have a leg ulcer while you're in hospital, well then we need to consider, are there other systems that are good that won't just need the calf muscle pump, even though you can encourage them to do their dorsiflexion while they're in bed. You want to actually improve or have that static kind of compression around the limb. So compliance and concordance, there's lots written in the literature about this, although they've paid very little attention to it over the last 10 years or so. I see only in the literature in the last kind of 2 or 3 years are they considering that the patient is actually a key part of this whole process. So we need to involve them in order to have compliance and concordance. So really what I say to the patients when they're going into compression system is, what works for you? If you need to get your shoes on, would it be better if we had a 2-layer system rather than a 4-layer system? Or if you have arthritis and you can't actually move your hands, how the hell are you going to get a hosiery stocking on and off going to bed? Okay, so there are applicators and there are certain slide technical applicators that you can get to help you apply these things, but very often a lot of people need assistance with applying them. But the patient's choice and their mobility will actually influence as well the choice of short stretch bandaging. And I suppose what we don't want is to spend ages and ages in the clinic putting on a beautiful bandage and then the patient just leaves and says, well, I'm not wearing this is a pain and I can't put on my shoe and I won't be able to drive with this now, so I'm taking it off. And the other thing patients think is they think that because they've got this big bandage on that they are completely immobile. So they start to walk funny and they don't use their calf muscle pump. So they're like they're in a plaster of Paris, and that's the last thing we want. We want somebody to walk normally because we want that calf muscle pump to work. Okay, so it's important that they make the choice with you and that they think about their mobility too. Just to talk briefly about allergies, over 200 patients patch tested, 13.5% tested positive to allergies, particularly to rubber or latex. So what we try to do these days is have latex-free gloves in the clinic and have latex-free products so that people don't get exposed to rubber allergies. If somebody does have a limb like this, obviously this person needs to be patch tested. And that's where they put a battery of tests on your back and they expose it to various different types of dressings, types of emollient, lanolin, rubber, latex, lots of different products. And whichever one comes up on your back means the one that you're allergic to. And they read it on day 3 and day 5. And then you can carry a little card saying, I'm actually allergic to silver, or I'm allergic to iodine. And then you can say to people, I'm not just being fussy, I really am allergic, don't put it on me, okay? So it's important to know about that. And then of course, when we put the hosiery on, if we don't put it on right, and if it's digging into the patient, and then they're walking around, or they're leaving their legs hanging down, of course they're going to get trauma here as well. So managing with the correct hosiery and the right fitting, everybody should be measured for their hosiery. And you're entitled to 2 pairs a year as well. So you can get those from the health centre. So things you can do is avoid exacerbating factors. So ideally what we want the patient to do is participate in their care. And we don't want them to leave the leg hanging down. Leaving it hanging down means gravity and all the fluid is going to go that way and you're going to have big problems. If you can keep your leg up, if you can do your dorsiflexion, if you can mobilise, all the better. So don't don't do anything that's going to cause more trouble. And of course people come into hospital and they have a particular slipper that they have at home, but because we feel them full of fluid, because they're always dehydrated, so they get loads of fluid and come into hospital, and then they start to swell up, don't they? And then some of them will be on diuretics or water tablets and maybe they're not mobilising, so they're going to swell. And suddenly now they're squishing their foot into the slipper to get to the toilet. And now they're going to get a pressure ulcer on their foot and it's going to start leaking as well, because they've not got the right shoe on. So it's really important that we avoid any of those exacerbating factors and make sure that we have shoes that fit us. Keeping warm is really important because it keeps the wound hydrated and it keeps the oxygen and nutrients to get to it. And of course having a healthy balanced diet and good exercise is important, and that's been reiterated here I think even before our lecture in the mental health lecture. So what we would say to patients is, if you do have a high BMI, think about losing weight. Think about what works for you, because if you aren't carrying the extra weight, it's easier for the blood supply to get back to the heart as well, and it's easier for you to mobilise. Exercise is really, really key, and of course avoiding smoking, because smoking narrows the arteries as well. It's going to cause more problems for you. So there are smoking cessation programs in most of the hospitals now, so there is help out there to help people think about giving up the smoking or alcohol or drugs. It's important to keep your skin clean, to moisturise with a mild emollient, something like Silcox base or something like that is useful. Use the prescribed compression appropriately. Guard against any cuts and injuries, keep on the lookout for problems, and then seek specialist advice if you're in doubt at all. So that's really important. So the majority of leg ulcers are venous in origin, as we said, about 80%. The problem I think these days is we're beginning to see more and more mixed vessel disease. So whilst you think you might only have a venous leg ulcer, very often when they come in and do the vascular assessment, there is an arterial component that needs to be dealt with as well. Okay? Or there are people out there with diabetes, because type 2 diabetes is on the increase, and they don't know they're diabetic. They've never been diagnosed. And it's only when we do glucose tolerance testing do we find out that maybe diabetes has an issue as well. And if you're diabetic and you have a wound, the way you heal that wound is totally different as well. So you need help in doing that too. So compression is the treatment of choice for ambulatory patients, and a good arterial supply to the limb. So we make sure that they have good blood supply before we put them in compression. And then choosing the right compression system means that the patient is actually going to comply with treatment as well. And there's nothing more frustrating for me if we ask the patient to wear compression therapy and they simply won't agree at all, and they just give up. So any sort of compression in my book is better than no compression at all. So what I'll try to do is I'll try to convince them to try some little bit of compression, and then we work towards the compression that we need, which is the 40 millimetres of mercury. But even if we can get them up to 20 millimetres of mercury of pressure, it's enough to close that valve a little. So with 2014 onwards, we have telemedicine, we have lots of people with apps and Google, and you have access to loads and loads of information. There's tons of it out there. There's patient information leaflets. But I think that this is really, really key, and we're going to see people with their iPhones and their apps interacting with their clinicians more and reporting to their leg ulcer clinics more. And I believe with this we can combat venous ulcer disease and manage the wounds a lot better. So as I said, there's lots of literature out there for you. If you want to follow up on it, it's available on the internet to download for free. So are there any questions? Thanks very much. So I think the key thing is to make sure that you get the proper diagnosis. So always attend your GP if you're worried. Make sure you get the right diagnosis. And for most people with venous leg ulcers, the treatment is compression. So although the topical treatment is quite important and managing venous stasis eczema is important, the most important thing is to get the compression right. And if you're not happy and if you're uncomfortable, seek advice as soon as possible.
From a personal point of view, on a professional level, I found it just fantastic to get another someone else's opinion and view, and their treatment of leg ulcers. I suppose for older people it's good that they get some information in general, you know, because it is something that affects the older generation.